Namaste, I'm Dr. Brihaspati.Sigdel. Today I'm talking CSF rhinorrhea, one of the most important topics in exam. Okay, now we start from the definitions. Is a leakage of CSF from the subarachnoid space to the nasal cavity. If you see, it is the brain here and nose here. This is the one of the roof there. So if there is something hole in the roof from which separate the brain and nasal cavity, then that lead to CSF leak from that hole. And there is a must be defect in the dura, maybe in bone or nasal mucosa. Incident-wise, it is a 0.3 to 0.5% in endoscopic sinus surgery. Why it is important? I think as it is the most important for endoscopic sinus surgeon, as functional endoscopic sinus surgery flourished all over the world by work of the Stamberger around 1990, then one of the leading surgery in the world. But that sometime lead to CSF leak. There is a more causes we discuss that one also, but for us that is important, so I mentioned here. Common site are cribriform plate, ethmoid roof, frontal and sphenoid sinus. What I see in this kind of cases is most of the common are cribriform plate and ethmoid roof. So this area is vulnerable, and that area lead to some injury, or may not be injury, but sometimes what happens is if you remove the polyp and there is a iatrogenic leakage later on because of there is a thinness and weakness of the cribriform plate and ethmoid roof. Other area we see when I work in Mumbai also, frontal sinus and sphenoid sinus, there is a maybe some way deficit in the congenital or later on. Classification wise, this is a older classification by Oma 1968. There are two types mentioned. One is traumatic, other is non-traumatic. Traumatic means accidental or surgical, or non-traumatic may be elevated intracranial pressure like tumor and hydrocephalus. We see the cases of benign intracranial hypertension, especially in the obese lady, and other are normal ICP, neoplasm, ectopic, and idiopathic. But later on, one of the leading surgeon, P.J. Owen from the Australia, which in 2003 revolutionized classification, which consists all the CSF leak into one group that is classified as follows. T for traumatic, S spontaneous type, M for meningoencephalus associated, and I for iatrogenic. Then what are the traumatic cases here? He include most common type. This one is the most common type, included especially head injury and skull base fracture. Common size, again same area, frontal sinus, cribriform plate, and ethmoid roof. If you see here in the CT scan, just outline here, this is the cribriform plate. You can see the Kestak Galai over here, and this is also almost stipple like that here. And you see here like there is a fracture and some leakage this side. This is the posterior roof of the frontal sinus. This one is the anterior roof, this is the posterior roof. There is a fracture and here is a leakage. This is the weakest area, and here what happens is dura is adherent to the bone, and this is tether and it start to leakage from here. Same way, if you start spontaneous within a week. Other type of spontaneous leak, CSF leak, what happened here is there is no trauma, there is no surgery, but there is a CSF leak. How it possible? There is a rise in intracranial pressure. Maybe there is a congenital defect also, but I focus in the rise in intracranial pressure, which is important in most of the examination, like any country license exam and American license exam, Australian license exam. Obese female coming with the OPD with headache, you have to think there may be increased intracranial pressure due to CSF overload. This is called idiopathic intracranial hypertension, and that chance there, if there is a defect, and lead to CSF leak. Other is meningoencephalocele CSF leak. We see some cases in the Mumbai. When I work in the Mumbai hospital, there is a leakage in the side, and this lead to maybe there is a meningeocele or meningomyocele, which is comes the bony defect here in the nose, maybe acquired or congenital. That time also there is a leakage and more brain tissue and durameter come down in the nose from the brain. Area again same area, carium plate area, sphenoid sinus area, temporal bone. I didn't see that much in temporal bone. Okay. Other is iatrogenic CSF leak. This is a post-surgical or post-complication, posterior complication can occur. If you do the endoscopic sinus surgery, we are now latest 2000 development of the pituitary surgery and skull-based surgery, so much there is a chance of CSF leak. Endoscopic skull-based surgery, we are working further down from the nose, that time also increase the chance of post-operative surgical complication like CSF leak. Some of the literature show earlier literature in 2008, so that is the famous surgeon from the Pittsburgh. This group find out that there is around 7 to 8% leakage of after pituitary or some skull-based surgery. This is seen in the intraoperatively or post-operatively. This should be managed by the endoscopic method. There are so many methods we discuss in the endoscopy, but most common coming in the this skull-based repair is using of the hard flap. Okay, we'll discuss later on also. Clinical feature wise, there is clear watery nasal discharge from the unilateral side. You have to think that one and see the patient. This is not snip back. If there is only mucus secretion from that, it is come down and go up. Like that, it go up. But in case of CSF leak, watery, there is a watery, will not able to sniff back. Post nasal deep and lying down, there is a postnasal dip also. There is an increased flow. If you do like that, okay, bending that time or Valsalva. If you do the Valsalva, that time increased flow of the this kind of CSF leak. There is a headache. Some surgeons saying that there is so much headache due to this kind of CSF leak. Other cause there is little headache. I feel there is a more chance of headache in such cases. And after leakage of the CSF leak, there is a decrease of headache is well known. Recurrent meningitis infection from the nose can go brain and cause recurrent infection. We see some feature of the CSF leak or nasal secretion, how to separate it. Yes, there is a surgery or no, you have to think of. If there is a sneezing or allergy cold, this is the allergic rhinitis type, this secretion from the nose. One is important here to mention here, if you taste this, that it becomes salty in case of the nasal secretion. In CSF leak, this is sweet. There is a sugar level is more than 30 in the CSF leak, which is little less or less than 10 in case of nasal secretion. Yes, sniffable is in case of nasal secretion, which I mentioned already. Beta to transfer is one of the most important biochemical tests, and this is present in CSF leak, otherwise absent in the nasal secretion. Diagnosis wise, there is a bedside test we can mention, but these are almost, we can do the bedside. Quick state test is a pressure. You have to do the pressure in the jugular vein. Some surgeons, what they do, see the jugular vein in the bilateral neck. Why this done is, if you press bilaterally, I am afraid of, okay, because unilateral pressure is okay, but if you pressure insist of jugular vein, you pressure the carotid, that time it's difficult. So I think it is the best appropriate method to see by the ultrasound both sides and give some pressure in the that in IGB, that time pressure increase in the brain, that lead to there is a CSF leak more from the nose. Other is reservation, there is a fluid, gush of fluid in the nasopharynx area. If you do like that, bending forward, that time this fluid is come out. Under chief test, this is other test which is CF does not sniff cloth. This old literature and most of the teacher asked about the halo sign. Halo sign is double ring when mixed with the blood. If you mix the blood, you can see CSF is going out here. This is the CSF area, this is the blood area. So halo sign, this is the halo sign. Most of the examiner you can ask in the exam. If you see the beta transferrin mechanism, beta 1 transferrin is produced by the liver and go to the brain. In case what happens is this, there is a cerebral neuraminidase. Neuraminidase enzyme in the brain. Okay, that what is caught between two. One is sialic acid and other beta 2 transferrin. Beta 2 transferrin is the brain, this one, but this remove the part of the sialic acid, which is after removing the sialic acid from the beta 1 transferrin, it becomes beta 2 transferrin. So it is very, very specific here because this is cerebral neuraminidase, which caught here there, caught the beta 1 transferrin. So this is only produced in the brain. If you see the lab test showing nasal secretion, beta 2 transferrin is high sensitive 100% and 95%, especially, which is almost a CSF. Other beta trace protein also, there is a marker. You can come with the exam also, it can be checked. We are testing the beta 2 transferrin in our patient in the ICU also, so that we confirm that it is CSF secretion or nasal secretion. Imaging. HRCT detect the bone defect, especially small slices. 1 to 2 millimeter slices is important here to do, and it has a 92% sensitivity and 100% specificity. If you see here, what we see is there is a defect in the skull base, especially in the posterior table of the frontal sinus. This is the Kistageli here. You can see the defect here, posterior table. This one is the anterior table of the frontal sinus. This is the Kistageli. Then CT cysternography, it detects the active leak, which is important to see in case of the surgery where we use metilzamide and hexol. MRI cysternography, yes, we can do in the T2 weighted and excellent for C encephalocele. Intrathecal fluorescent help localization and confirm repair. If you see that this endoscopic picture, this is almost same leakage here, and it look like greenish yellow. If we do use the blue filter, it will see apple green. Management wise, we have to do conservative management. Answer come like tail, bed raise, head elevation, use the stool softener, and yes, some surgeons prefer to do acetazolamide to reduce CSF formation. I am not happy with this acetazolamide. Lombardane, yes, Lombardane can be used in high pressure leak cases 2 days before the surgery in skull base cases. Surgical indication, at least if there is a CSF leak, you have to wait for the 10 days. And if there is a recurrent meningitis in the patient and large persistent defect, after 10 days also to do surgical repair. Approach, I prefer the endoscopic approach, around 97% success rate. There is a discussion of intracranial and extracranial approach, now almost replaced by the endoscopy approach. Graft, there are different graft material. Most common is the ear lobule graft, and next one is fascia lata and mucosal graft, Hadar flap, crucial here, which is a pedicle vascularized flap, Hadar flap. So what is the way you have to repair the CSF leak? Take the some nose. I think I need a strong base, so fascia lata more prefer. Some fat lobule is small, 1 to 2 millimeter perforation. Use ear lobule or thigh fat. Cartilage synthetic murder, I am not interested on that. So technique way, there is so many technique described in literature: overlay, underlay, back plug. Overlay means you have to put the graft inside for just underlay. Fovea ethmoidolis is a good. It is difficult to sphenoid defect. Only you have to put the graft under the bone, the nose side. That is overlay. Underlay, you have to insert that graft material, means fascia lata, inside the bone skull base, and it is between the dura and bone. Bath plug technique describe and it is done for hole, small hole in the skull base. It use the fat plug and mucosal graft cover after that. Sandwich technique also described maybe both technique under the overlay after that cartilage also, but double layer of facial atta is that much extra. No need of cartilage uh, in this kind of technique. After that, we put the fibrin group. Post-op care is crucial here. Bed days, head should be elevated 15 to 30 degree. Stool softener, no coughing. Okay. Lumbar day, at least 5 days. Uh, Other acetazolamide antibiotics should be given. Yes, we have to monitor for the recurrence of the CSF leak because there is a failure of the cases 6 to because it is the most one important again price intracranial pressure. So that time it needed CSF son. Thank you.